Visible and audible to you people? Kindly someone confirm visibility audibility is great so we can go ahead. Confirm it in the chat. Okay, thank you. Thanks a lot those who have confirmed it. Thank you. So I welcome you all for today's session. A very good morning to all of you. And I am Dr. Priyanka Sachdev. Today I am going to continue a topic from pathology, systemic pathology. I am going to continue cardiovascular system CVS. Yesterday we have started a new batch, a free batch for second prof subjects, that is pathology, pharmacology and microbiology. In this free batch I am going to cover these three subjects cover to cover, and I will prepare you for theory as well as MCQs. So this batch will be useful, highly useful for the second prof MBBS students of all the medical colleges, and also for the aspirants of NEET PG, FMGE, INICT or next who are preparing for these competitive exams, because in this batch I am going to cover theory as well as MCQs. So without wasting time, I'm just continuing it. Yesterday we have started CVS. We have covered some topics in CVS. We have covered heart failure, cardiac adaptations, myocardial infarction, coronary artery disease, ischemic heart disease. We have already covered it yesterday. MI was in the middle. I know. I will continue it later. Currently, I am starting with a fresh topic, that is endocarditis. And in the end, I will continue with MI. The clinical features of the MI yesterday I have left in between. So I'm just starting from endocarditis today. So it is a very important topic, not only in pathology, but also in medicine. The same topic you have to study twice, once in second prof and once in final year. So you have to study endocarditis twice, once in pathology, once in medicine. So I try to cover endocarditis completely from the pathology also and from the medicine also. So the topic is complete. So I'm starting with endocarditis. What is endocardium? For understanding endocarditis, you should know what is endocardium. What is endocardium? So we know this is heart. These are the four chambers of the heart. This is the right side. This is the left side. You can see this is left auricle, left ventricle. All the auricles and ventricles, all the complete heart walls are lined by three layers. The innermost layer is endocardium. The middle layer is myocardium. The middle layer is myocardium. And the outermost layer is pericardium. So there are three layers: endocardium, myocardium, pericardium. Today I am teaching you endocarditis. Endocarditis is the inflammation of the endocardium. So this endocardium, which I have drawn with purple color, can you see this endocardium? When this endocardium, that is the innermost layer of the heart, when it gets inflamed, the disease is known as endocarditis. Now, why it is an important disease? Now, we know there are walls in the heart. I have already told you yesterday, heart have four walls. So you can see here on the left side, there is a mitral wall, and on the right side, there is a tricuspid wall. We know these are AV walls, atrioventricular walls. Also, we have semilunar walls, aortic wall and pulmonary wall. So these walls are made up of which layer? Endocardium or myocardium or pericardium or all of this? That is my question to you. Walls are made up of which layer? Yes, Jaydev, you are right. Walls are made up of endocardium. So walls are made up of endocardium. So when we have endocarditis, these walls are also get involved. So when these walls are get involved, patient will have valvular disease. Patient will have small vegetations over these walls in endocarditis. So I will teach you all types of endocarditis and the valvular involvement in them. Which wall is involved, what is happening, what is the clinical features of that. So that is why this endocarditis disease is very important. So in endocarditis, there is inflammation of the inner layer of the heart, that is endocardium. Myocarditis also we will study later on. Today I am teaching you endocarditis. Then we will study myocarditis also, pericarditis also. All the three layers of the heart can be inflamed. They all can be inflamed together. They can be inflamed separately. So most important among these three, endocarditis, myocarditis, pericarditis, the most important from exam point of view is endocarditis. So endocarditis is the inflammation of the inner layer of the heart. And because heart walls are made up of endocardium, I have told you. So here heart walls are also involved. So that is the thing. So here you can see the walls of the heart. These are the walls of the heart. If I zoom out this portion, you can see the walls are involved here. Small vegetations will be there. So what are the types of endocarditis? How many types of endocarditis I am going to teach you today? I will teach you 4 types of endocarditis. So this is the classification of endocarditis. So there is rheumatic fever, in which not only endocardium, myocardium and pericardium is also inflamed. So in rheumatic fever, there is pencarditis. The word pen means all the layers. Pencarditis, not only endocarditis, it is pencarditis. So pencarditis includes all endocarditis, myocarditis, and pericarditis. So all three layers of the heart get inflamed in rheumatic fever. Basically, I am concerned with endocardium, but I will teach you myocardium, pericardium also in rheumatic fever. So that is known as rheumatic fever endocarditis. So we will start with rheumatic fever and rheumatic heart disease. So I will teach you pancarditis there. And non-rheumatic endocarditis, there are three more. Total, there are four endocarditis. So three more. What are those? Number one is Libman-Sec. Libman-Sec is SLE endocarditis. There is endocarditis and SLE. You know what is SLE. So that is Libman-Sec endocarditis. You have to learn these names. There is NBTE, non-bacterial thrombotic endocarditis, which is also known as merantic endocarditis. We will study this also. And in the last and most important is bacterial endocarditis or infective endocarditis. So total, I am going to teach you four endocarditis. What those? Number one, rheumatic endocarditis. We will start with rheumatic. Number two, Libman-Sec endocarditis. Number three, NBTE, non-bacterial thrombotic endocarditis. And last is bacterial endocarditis or infective endocarditis. I advise you to make a table like this, which I am making it for you. So I advise you to make a comparative table of the four types of endocarditis. I will make you table also, which I have made or which is available in the books. In Robbins, in Hirschman, it is available. But if you make it by your own, you will never forget. So whatever things we study, whatever things we read from anywhere, we can forget that. But whatever things we write now, we never forget. So that is scientifically proven fact. So whatever things you will write by your own now, you will never forget. So just make a habit of making notes of your own. So notes are available of all the educators, of all the faculties on Telegram, everywhere notes are available. But if you make your own notes now, you will never forget. Whatever you are writing now, you will never forget. So my advice to you to make this table of your own. So we will study four types of endocarditis. Number one, rheumatic, and number two, non-rheumatic. Non-rheumatic contains three. So I will start with rheumatic endocarditis. This is a table which I am talking about. In the end, we will study this comparative table. So I am starting with rheumatic fever. Now, what is the difference between rheumatic fever? What is the difference between rheumatic fever and rheumatic heart disease? They are one and the same thing or something different? Now, rheumatic heart disease is a part of rheumatic fever. Rheumatic fever is an umbrella term. It contains 5 diseases. Out of these 5, one of them is rheumatic heart disease. Now, what do you mean by this? What do you mean by rheumatic fever? What is rheumatic fever? Yes, what is rheumatic fever? For understanding rheumatic fever, I will give you the complete theory. Just listen, just listen. Everything is available in the notes. Listen. So I will tell you a story. Listen, there is a child whose age, let me draw it. There is a child whose age is 5 to 15 years. These are the tonsils of the child. So child got pharyngitis. So this is a bacteria which is causing tonsillitis or pharyngitis. The red colored dots is the bacteria. Which bacteria? It is group A beta streptococcus bacteria. Group A beta streptococcus bacteria is causing pharyngitis or tonsillitis in a child whose age is 5 to 15 years. So what will happen? Body will make antibodies for the bacteria. So this is the antibodies. Antibodies formed by the body of the child. In the child, antibodies are formed against the antigens present in the bacteria. So these antibodies will bind with this bacteria and antigen-antibody reaction will take place and bacteria will be neutralized and tonsillitis will be subsided. Okay, why I'm telling you this story here? Why I'm telling you it is not so simple. Why I'm telling you this story here? Now, in the body of this child, there are 5 organs. There are 5 organs which contains nearly same antigen as that of bacteria. So what are those 5 organs? Number 1 is brain of the child. Number 2 is heart of the child. Number 3 is skin of the child. Number 4, just below the skin, there is subcutaneous fat just below the skin. And number 5 are joints of the child. Joints, let me draw a bone. So joints, these are the 5 organs which contains a antigen which mimics bacteria. Not exactly, but there is a mimicry on the skin, subcutaneous tissue, joints, brain and heart. So these antibodies will get confused. They will do cross reactivity. These antibodies will think on these 5 organs there is bacteria. Actually, it is not bacteria. It is not bacteria. It is the antigen of the child itself. But these antibodies will get confused and they will do cross reactivity on these 5 organs. Just tell the name of these 5 organs. Number 1 is brain. Number 2 is heart. Number 3 is skin. Number 4 is subcutaneous tissue. Number 5 are joints. सो स्किन के नीचे सबक्यूटेनियस टिश्यू, उसके नीचे जॉइंट. सो तीन तो ये हो गए, एंड ब्रेन एंड हार्ट. सो टोटल 5 organs. So these antibodies will bind with the antigens on these 5 organs by confusing. So because of confusion, these antibodies will think it is a bacteria, but actually it is not a bacteria. It is body's own antigen. This is known as cross reactivity, molecular mimicry and cross reactivity. What term I am saying? Molecular mimicry. Mimicry kisne ki? Who is doing the mimicry? Mimicry is done by these 5 organs. These 5 organs have antigen which is doing mimicry as that of bacteria. So cross reactivity is done by the antibodies. So these 5 organs will be involved in the child. So in the child, these 5 organs will be involved and 5 diseases will be there in the child. So in the brain, there will be a disease known as syndrome scoria. In the brain, due to this antigen antibody reaction, there is a disease known as syndrome scoria. In the heart, there is a disease which is known as rheumatic heart disease or carditis, carditis, rheumatic heart disease. In the skin, there is a disease which is known as erythema marginatum. I will tell you, it is given in the notes. Just listen. In the subcutaneous tissue, there is a disease known as subcutaneous nodules. And in the joints, there is a disease which is known as migratory polyarthritis. So these 5 diseases together are known as rheumatic fever. So child is suffering from rheumatic fever. Rheumatic fever is an umbrella term which is containing these 5 diseases. These 5 diseases together known as rheumatic fever. I will teach you all 5. So if you are a second prof student and question in your exam is coming on rheumatic fever, you have to write all 5. And if question is coming on rheumatic heart disease, you have to write this one only. So out of these 5, the most important organ which is involved is heart. So I will teach you rheumatic heart disease in detail, and rest of the 4, I will give you some important points. So I will teach you all 5. That is rheumatic fever. It is an umbrella term. Any doubt in this? What I have told you, the story of the child. What is rheumatic fever? So there is a child. You can see the child here. So this is a child. These are the tonsils of the child. Child got an infection by bacteria in the tonsils. Child got pharyngitis. What is the age of the child? It is most common in 5 to 15 years. Correct or not? So the bacteria which is involved is group A beta streptococcus bacteria known as GAS, GAS, group A beta streptococcus. Never forget, it comes in MCQs. So this bacteria causing tonsillitis, pharyngitis in the child. So body is forming antibodies. I have drawn with green color. Body is forming, the body of the child is forming antibodies for this bacteria, for killing this bacteria, for doing antigen antibody reaction, neutralizing the bacteria. So antigen is present in the bacteria and body is forming these antibodies and neutralization takes place. So bacteria to mar gaya, bacteria is dead, bacteria is neutralized by this antibody, bacteria is not causing any harm. Instead of tonsillitis, that is also subsided. So, but this antibodies will get confused because 5 organs in the child. What are the 5 organs? Name it. That is brain. Number 1 is brain. Number 2 is heart. Number 3 is skin. Just below the skin, subcutaneous tissue. And last is joints. So these are the 5 organs you have to learn. On these 5 organs, there is an antigen which is present, which is doing molecular mimicry as that of bacteria. So antibodies will get confused and they will do cross reactivity on these 5 organs, producing 5 diseases. So that is the 5 diseases together known as rheumatic fever. Any confusion in that? So I will teach you rheumatic fever. So that was the story. If you understood the story, now see the theory. So just see the theory. So I will teach you rheumatic fever in these headings. If you're a second prof student, note down these headings. Rheumatic fever always comes as a long question in your exam, long essay question for 5-mark question. So you have to write 4-5 pages on it. So these are the headings in which you have to describe it. So we will take it one by one. So what is rheumatic fever? Now you tell me. If you understood, you tell me what is rheumatic fever. It is a multi-systemic disease because 5 organs are involved, not one. So it is a multi-systemic disease, yes or no? It is always post-streptococcal. And listen, one more thing. Here in the diagram, I have told you whatever the 5 organs are involved in the child, it is not involved by the bacteria. It is involved by body's own immunity. So can I say rheumatic fever is an autoimmune disease? So 5 organs involved by body's own antibody. Bacteria to mar gaya. Bacteria is doing nothing. The 5 organs involved by body's own antibodies. So it is an autoimmune disease. It is not caused by bacteria. It is caused by body's own antibodies against own antigen by confusion, by cross reactivity. The mechanism here is molecular mimicry and cross reactivity. That is the thing. So it is a multisystemic disease. Yes. It is always post-streptococcal. Yes. It is non-suppurative. Pus is not formed because bacteria is not involved. Pus is formed there where bacteria is involved. Here no bacteria is there. So it is non-suppurative. And it is non-suppurative, but it is inflammatory disease. And it involves 5 organs. Name the 5 organs: heart, joints, CNS means brain, skin, and subcutaneous tissue. So you know the name of the 5 organs already. So rheumatic fever is an acute disease. Yes, it is immunologically mediated because it is caused by antibodies. It is multisystemic because it involves five organs, and it is caused by group A beta streptococcal pharyngitis after that. So this is the definition. The 5 organs involved you already know. So that is the definition. So that is the same diagram. I have drawn it for you. So this diagram is from Robbins. So can you see, this is a child. These are the tonsils of the child. These are involved by a bacteria. Can you see the red colored rods here? The red colored rods are the bacteria. Body is forming antibodies against that, and that antibodies is involving heart also. All the layers of the heart. So in the heart, there will be pancreatitis. And most common age in which rheumatic fever occurs is 5 to 15 years. So it occurs in a child, never in adult age. So usually it occurs in child. It is very rare, less than 3 years. Mostly 5 to 15 years child are involved. And girls are more involved. And it is more common in overcrowding, poverty, poor sanitation. And what is the incubation period? What is incubation period is 2 to 5 weeks. So child will have tonsillitis, and after 2 to 5 weeks, the 5 organs will be involved. Not immediately, because body requires some time to form antibodies. Now, if I'm a child, just suppose I'm having tonsillitis by group A beta streptococcus bacteria. So body will form, I'm having pain in the tonsils, I'm having fever because I'm having tonsillitis. So body will form antibodies, and those antibodies will involve my 5 organs. It will take 2 to 5 weeks. So rheumatic fever, the incubation period for the rheumatic fever, never forget, it is 2 to 5 weeks. So if you're a doctor, if a mother or parents are coming, taking their child to you, that my child is having some problem, and they are giving you symptoms which is showing involvement of multiple organs, you should always have a suspicion whether the child is having rheumatic fever or not. If heart, brain, skin, subcutaneous tissue, and joints, multiple organs, it is not necessary all 5 organs are always involved. More than one can be involved, but not necessarily all 5 are always involved. So you should have a suspicion. You should always have a suspicion there that child may have rheumatic fever. So you should always ask the mother whether before a month or some weeks before the child was having tonsillitis, say yes or no. So you should always take this history. It is very important. If the mother is saying yes, 2 weeks or 3 weeks before he was having tonsillitis, but it is subsided, we don't bother. We are not bothered about it. We are bothered about this symptom now. So you should always know it is a post-streptococcal disease. So it can be rheumatic fever. So you will do the investigations, and you will come on a conclusion whether it is rheumatic fever or not. But first thing is you should have a suspicion. Being a doctor, what investigation to be done judiciously, you should know what it will depend on what suspicion you are having. So based on the symptom, if a child is coming, the age of the child is 5 to 15 years and multiple organs are involved, you should always have a suspicion child may have rheumatic fever. And the most important history you have to take from the parents or the mother is whether the child is having tonsillitis few weeks before or not. Say yes or no. So that is the thing. So that is the epidemiology here important. Coming on pathogenesis, I have already told you the pathogenesis. Say yes or no. It is an autoimmune disease. Yes or no. It is not caused by bacteria. It is not caused by bacteria. It is caused by body's antibodies, autoantibodies. So what is happening? There is a child. Child is a susceptible host. 5 to 15-year child. Child is affected by group A beta streptococcus infection, gas. Group A beta streptococcus infection, gas infection. That is having tonsillitis or pharyngitis. The tonsils are involved. So body will form antibodies for it, autoantibodies. These antibodies are autoantibodies, and these antibodies will damage 5 human tissues, 5 human organs, because they have same antigen as that of bacteria. So antibodies will get confused whether it is a bacteria or whether it is a body's own antigen. So they will damage the 5 organs. You know the 5 organs. What is the antigen which is common in bacteria and on these 5 organs? Name of the antigen. I have told you the antigen which is present on the bacteria, the same antigen is present on these 5 organs. So antibody get confused, it will destroy bacteria also, these 5 organs also. Name the antigen. The name of the antigen is NAG, N-A-G, N-acetyl glucosamine. Never forget, again important MCQ. N-acetyl glucosamine. It is the antigen which is present on bacteria also, and it is present on these 5 organs also. Say yes or no. Yes or no. So there is a molecular mimicry. There is a molecular mimicry. Antigen is present on these 5 organs, the same antigen present on the bacteria, that is, and body is doing cross reactivity. So the mechanism involved for rheumatic fever is molecular mimicry and cross reactivity. Take these important words and make your own sentences. Don't learn it, don't mug up. Just understand the things and write by yourself. So molecular mimicry and cross reactivity is the phenomenon which is taking place here. Yes or no? Now, just suppose 100 child are involved by group A beta streptococcal pharyngitis. Tonsillitis is so common ना, आपको भी हुआ होगा बचपन में, मुझे भी हुआ है. Every child have tonsillitis pharyngitis in their childhood. So does all the childs which have tonsillitis or pharyngitis in their childhood will have rheumatic fever? No, only 3 of them out of 100, 3%. So percentage is 3%, less than 3%. So the rest 97 will be cured, but 3% will have a consequence of rheumatic fever. So incidence rate is 3%. Never forget. Incubation period is 2 to 5 weeks. You have to take these words. Correct or not? So that is the same diagram it is shown. This is a child. This is the tonsillitis. Cross reactivity will take place. I have given this flowchart. Now there is a scientist there is a person known as Jones. Jones is the name of the person who has given criteria to the doctors for diagnosing rheumatic fever. Now you are a doctor sitting in your clinic, mother is coming with the child, mother will give you some symptoms. My doctor, my child is having this. So what are the criteria based on which you will say your child is having rheumatic fever? There should be some criteria, na? So these criteria are known as Jones criteria. Very, very important. So Jones has given 5 major criteria and 5 minor criteria. Total 10 criteria are there. So in Viva also this question is very common because you always have a specimen of heart in your final exams, in practicals. So there is a heart specimen which is having vegetations or rheumatic heart disease. So Viva always shift here. And once the Viva is on rheumatic fever, rheumatic heart disease, Jones criteria is always asked. And there's important question for theory also and MCQs. I will put MCQ in the polls. You yourself will see how important it is. So Jones criteria, very, very important. Total 10 criteria are there. 5 major, 5 minor. I will tell you. So being a doctor, you should know these criteria correctly. So these are the 5 major criteria are the 5 diseases. 5 diseases in the 5 organs. You already know it. So in the heart, name the disease in the heart. What is the disease in the heart? It is rheumatic heart disease, RHD, rheumatic heart disease in the heart. What is the disease in the brain? Say the disease in the brain. Brain में कौन सा है? It is syndrome scoria in the brain. Brain हो गया, heart हो गया. Coming on skin. What is the disease in the skin? Name the disease. It is erythema marginatum. We will study all these diseases in details. Don't worry. So just learn the names first. So in the skin, the disease is known as erythema marginatum. Just below the skin, there is subcutaneous tissue. What is the disease in subcutaneous tissue? Name the disease. It is subcutaneous nodules. Subcutaneous nodules. And last organ is joints. What is the disease in the joints? Name it. It is polyarthritis, or write it completely, migratory polyarthritis. So these 5 diseases together are the major criteria. So 5 major criteria is nothing. It is the 5 diseases which is caused by this antibodies. So you know it? Yes? Say yes or no. The 5 diseases you know. So in rheumatic fever, you know the 5 diseases. So this is the diagram showing the 5 diseases. So in the brain, it is syndrome scoria. In the heart, it is carditis. In the joints, it is polyarthritis. In the subcutaneous tissue, it is subcutaneous nodules. In the skin, it is erythema marginatum. So I will tell you. So these are the 5 major criteria. Now coming on minor criteria. So what are the 5 minor criteria? Child will have fever. Not now, 2 weeks before, when he was having tonsillitis. So when child was having tonsillitis, pharyngitis, jab bhi tonsillitis, pharyngitis, it's a bacterial infection, na? So child will have fever also. So mother will say child was having tonsillitis, pharyngitis 2-3 weeks before, and he was having fever also. So fever is a minor criteria that will support your diagnosis. So it is not major, it is minor. Now this is the first minor. Second minor is arthralgia. Please mind my words. Arthralgia is a minor criteria, and arthritis, polyarthritis is a major criteria. Now there is a difference between polyarthritis and arthralgia. What I am saying you, arthritis and arthralgia. Arthralgia. Now what is the difference? Arthritis is the inflammation of the joints. Arthralgia is the pain in the joint. So inflammation in the joint, that is polyarthritis, migratory polyarthritis, it is a major criteria. And arthralgia is pain in the joints, that is a minor criteria. So just take these words. These are tricky MCQs which comes in the exam, so you have to take it. So that is arthralgia. Previous history of rheumatic fever, another minor criteria. You will ask some blood test to the parents to do some blood test of the child. What blood test you will ask? You will ask for ESR, erythrocyte sedimentation rate, CRP, C-reactive protein. Now we are doing CRP for all COVID patients, now you know. So CRP and leukocytosis, that is WBC count. So all these will be raised. ESR will be raised, CRP will be raised, and WBC count will be raised. So these three things raised in the blood of this, in the blood sample of the child, that is a minor criteria. And last is, you will ask for ECG. Heart is involved now. So heart is involved, you will ask for ECG. In ECG, there will be prolonged PR interval. You know PQRST waves in the ECG. So PR interval is prolonged. So these are the 5 minor criteria. Now, can you enumerate 5 major, 5 minor? It should be on the tip of your tongue. Total 10 criteria. Never forget. These are Jones criteria. So you are a doctor sitting in your clinic. Child is coming to you with the parents. Parents are giving some symptoms. You will see whether the child is having these major criteria, yes or no, whether the child is having these minor criteria, yes or no. Now my question to you, how many major you can find in the child and how many minor you see in the child, then you will quote the child is having rheumatic fever. You will say, parents, that your child is having a disease. The name of the disease is rheumatic fever. How many major and minor? It is not necessary all 10 will be present in a single patient. No, it never happens. So how many major and how many minor minimum you should see in the child before labeling the child as rheumatic fever? That is my question to you. Do you know? So you can't approximate 2, 3. You should be exact. You should say it exactly. Either out of, there are 5 major, 5 minor, you know. So from the major, if 2 major are there, no need to see for minor. 2 major is sufficient to quote the child as rheumatic fever. 2 major are there. Or if 1 major is there, along with 1 major, there should be 2 minor. So there can be 2 things. Either there should be 2 major. Just a second. Either there is 2 major or 1 major and 2 minor. So इससे ज़्यादा होगा तो चलेगा, इससे कम नहीं होना चाहिए. If more than that, it is okay. Sometimes all 10 you can find, but इससे कम, less than that is not a criteria. So to label a child, I'm sorry, just a second. To label a child as rheumatic fever, there should be 2 major criteria or 1 major and 2 minor criteria. Say yes or no. Have you got it? So you can see the child is having tonsillitis here. Can you see the pharyngitis in the mouth of the child? You can see the tonsillitis, pharyngitis here. And there is a mnemonic for Jones. So the major criteria, you know the name of the 5 major. So you write the spelling of the Jones. Jones. So from J, you can see joints. Joints are involved. Polyarthritis. O, from O you make a heart. That is carditis. Make O as a heart. N means nodules, subcutaneous nodules. E means erythema marginatum. And S means syndrome scoria in the brain. So this is a mnemonic. You can learn it by mnemonic itself. You can learn it whatever comfortable to you. So that is Jones. Jones से ही हमने mnemonic बना दिया. So these are the 5 major criteria. 5 major criteria. So these are 5 major criteria. These are 5 minor criteria. Now my question to you, I'm asking something to you. Listen, what I'm asking to you, you are a doctor sitting in your clinic. A child is coming to you with the parents. You found 1 major. What major you have found? You have found the walls, you have auscultated the child and you found some murmurs in the child. You have done an ECG and you found the PR interval is prolonged and some valvular disease is there. So you found 1 major, now heart is involved. Valvular disease is there, murmurs is there and heart is involved. You found it. Number 1, heart failure is there in the child. And you found one more major. Just suppose you found erythema marginatum in the child. So you found 2 major. And you ask the mother whether there was a group A streptococcal infection 2-3 weeks before, tonsillitis 2-3 weeks before, yes or no. Mother is saying no. I'm not remembering, my child was having tonsillitis since long. So my child was not having tonsillitis or pharyngeal pain since long, since last 1-2 years he's not having. So whether you will code the child as rheumatic fever or not, you have found 2 major or 1 major 2 minor, you will say rheumatic fever yes or no. That is my question to you. You have to answer it, then I will tell you what is this correct answer. Some are saying yes, some are saying no. You should have an explanation for it. It is not a guess कि तुक्का मार दिया कुछ भी बोल दो. Why yes? Why no? Why yes or why no? So yes, Sushma is right. So you have to be judgmental before saying your answer. You should give a proper explanation. Why yes or why no? So 2 major, Prabhakar, it is not sufficient. Just 2 major or 1 major, 2 minor. It is not just sufficient. It is not sufficient. So after this problem was coming to many doctors, so Jones criteria were revised in 2015. So there are revised Jones criteria which we use nowadays. We don't use Jones criteria. So in your Viva exam, first the examiner will ask you Jones criteria. You will say 5 major, 5 minor. If you answer it correctly, then next question will be what is revised Jones criteria. So nowadays we use revised Jones criteria. We don't use Jones criteria. What is the difference? What is the difference? What is the revision? What revision is done? So 5 major is same. 5 minor is also same. Major is same, minor is same. But some extra criteria are added in the revised zone criteria. That is known as group A beta streptococcal infection criteria, gas criteria. That is a supportive criteria. So child should have a history for tonsillar pain, for pharyngitis, without which we cannot say it is a rheumatic fever. It may be coincident, na? Child is having 2 major problems separately. It is not a rheumatic fever. If the child is not having streptococcal infection and child is having carditis by de novo, it is not rheumatic fever. It is not. For having rheumatic fever, child should have tonsillitis by group A beta streptococcal bacteria. Then only you will label it. But you have to prove it in the lab, na? Whether the child is having this infection or not. Whether just saying the mother is saying no, I'm not remembering it. Maybe child is having very subtle pain in the tonsil and mother is not knowing the child was having tonsillitis 2 weeks before. Then it may be false negative, na? So you should confirm it in the lab whether the child is having tonsillitis or not 2 weeks before. You should confirm it, and those criteria are known as gas infection. Gas infection criteria, that is group A beta streptococcal infection criteria. Supportive criteria, that is added in revision. So what you will do? You will do a swab. Nowadays, the throat swab is done for the COVID. Now, in the same way, throat swab is done from the child, and we will culture the swab because it is a bacteria. We can culture it. Now, nowadays, COVID is a virus. We cannot culture it. We are doing RT-PCR from the swab. But here we can do the culture. So you are doing the swab from the throat, from the tonsils of the child, and you can culture it. On the culture, bacteria will be there. If present, it will grow on the culture. Yes or no? Or you can take the blood sample from a vein of the child and you can see the antibodies. If bacteria was there 2 weeks before, antibodies should be there. So which antibodies you will test? There are 2 antibodies. Anti-streptolysin O, ASO, anti-streptolysin O titer. These antibodies or anti-DNA antibodies. So these 2 antibodies you will look for in the blood of the child. Out of these 3, if any one is present, it is confirmed that along with these 2 major and 1 minor, if any of the gas criteria is present out of these 3, it is confirmed that child is having rheumatic fever because of streptococcal infection. So it is Jakriya and Jaidev, they are asking that after 2 to 3 weeks, culture may be negative. Yeah, I agree. Culture may be negative, but sometimes it may be positive. What is the harm in doing the culture? So you can culture. Sometimes a very minute amount of bacteria is still present in the tonsils. Pain is not there. And bacteria is not completely eliminated. Or sometimes dead bacteria is present. So you can culture it. You should always culture it. So, and antibodies can be present. So do all 3. Out of the 3, even 1 is positive. The 2 antibodies and 1 culture, you can take it as positive. This criteria is positive. So what are the revised Jones criteria? Revised Jones criteria says this. There should be 2 major or there should be 1 major, 2 minor along with gas criteria. Gas to hona hi chahiye. Group A streptococcal infection criteria should be there. So there are 5 major, there are 5 minor and 3 gas criteria. That is revised. Out of which what should be there to label it, you know. Yes or no? Have you got it? Should I proceed ahead? Say yes. Any doubt in this? Any doubt in this? We are done with Jones criteria. Jones criteria, let me revise your Jones criteria. There are 5 major criteria. You will tell me what are those. There are 5 minor criteria. You will tell me. I'm not going to tell you. You will tell me. And there are three group A streptococcal infection criteria, supportive criteria, you can say. They are three. So five major, five minor, and three supportive. You have to tell the names. First, coming on major. Major are very easy. Major is Jones only. That is in the brain, it is syndrome scoria. In the heart, it is carditis, rheumatic heart disease, or carditis. In the skin, it is erythema marginatum. In the subcutaneous tissue, it is subcutaneous nodules. And in the joints, it is polyarthritis, migratory polyarthritis. These are the five major. Five minor, you know? Say yes or no. What are the five minor? It is fever. Patient is having fever. Child is having fever 2-3 weeks before. Child is having arthralgia, not arthritis. Mind it, arthralgia. And blood में तीन चीजें, ESR, CRP, and WBC count is raised, and PR interval on ECG is raised, and a previous history of rheumatic fever. These are five minor. And what are the group is streptococcal criteria? Three criteria. Number one, culture positive. Culture for the bacteria is positive, number one. And number two, antibodies. Which antibodies? Name it. Name it. Anti-streptococcal O antibody. And number two, anti-DNase antibody. So just write it down by yourself. You will never forget. Please take my words. Whatever things you write by yourself, now you don't forget even after years. Even after years, whatever you read, whatever you say, you can forget. Whatever you write, you don't forget. Make your own notes. Whatever faculty notes you are following, it's good. Just read the notes from the faculty notes. Make your own notes by combining the notes of all faculties. So that is my advice. If you want best result, if you want to your rank in top 100 in whatever competitive exam you are targeting, you have to read notes of multiple faculties. Not only you can't follow the one. I am not the best. Maybe I'm missing something, so someone else is covering that. So just read the notes of everyone, whatever available to you. Just read, and compile all. Make your own. Make your own. Just compile all. Make your own notes by compiling all. So just start making by today only, so that on your big day in the last month of your revision, you can just read your notes. Don't follow here and there. Just make your own notes. You will never forget. Take my words. Once you will be selected, now you will come and say thank you to me. That is a big advice I am giving to you. That is a big advice. Now those who are following, समझदार के लिए इशारा काफी है ना. So those who are following, they will remember me. Correct. So I would like to launch some polls here. Correct. Are you ready for the polls? Are you ready for the polls? So then we will start the five criteria in details. Five major criteria I will teach you in detail. So this is the first poll. I will give you only 15 seconds. So be fast. So just a second. Let me launch. Yeah. Do it fast. What is the mechanism of rheumatic fever? Read the options. Don't rush. You have to be fast and accurate also. Yes. What is the mechanism of rheumatic fever? I have told you the mechanism of rheumatic fever. All of you are correct. Most of you are correct. The correct answer here is cross reactivity and endogenous with endogenous antigen. That is molecular mimicry and cross reactivity. So the correct answer here is A, Samarth, M, and Divya are first to answer. So this is the leather board in front of you. So that was the first question. Correct answer is A. This is the second question in front of you. Do it fast. Which is not a major criteria. Please see the word not. Which is not a major criteria for rheumatic fever. Not. Yes. 4 options are in front of you. Most of you are correct. I'm happy you are getting it. Most of you are correct. Yes. Good. So which is not a criteria? Yeah, tell me. So carditis, it is a criteria, of course. Pancreatitis, rheumatic heart disease, one and the same thing. Arthritis, yes, arthritis is a major criteria. Arthralgia is not, but arthritis is there. And subcutaneous nodules, it is also there. But increase ASO titer, anti-streptolysin titer, increase ASLO titer, it is a gas criteria, not a major criteria. So the correct answer here is C, because not is asked, except is asked. So correct answer is C. So Divya, Mohit, and M are first to answer it correctly. Okay, so the correct answer here is C. Good. So this is the next question in front of you. Which of the following is not included in major criteria? Not included. Again, the question is not. Again, the question is not. Yes, the same question with different options. The question is same. Which is the following is not. Okay, I have not launched it. Just a second. I just forgot to launch it. Okay. Mark it. Yes. Okay, most of you are correct. Yes, the correct pancreatitis, it is a major criteria. Chorea is syndrome scoria. Short form is chorea. The complete name is syndrome chorea. Subcutaneous nodule, it is also there, but high ESR, it is a minor criteria, not major criteria. So the correct answer here is D, because not is asked in the question. Correct answer is D. So Samarth, Sheikh Saifuddin, and Yashika Bhaki are first to answer. Okay, good, guys, good. So the correct answer here is D. Coming on the next question, this is the next question. Just read. Again, the question contains except. Which of the following is not a major criteria? Question is same. Options are different. Question is same. All of the following are major criteria of rheumatic fever except. Question contains except. I always highlight except. So don't get confused. So I'm happy you people are correct. You got the point. The question is tricky one. So carditis is a major criteria, syndrome chorea is a major criteria, subcutaneous nodules is a major criteria, but migratory polyarthralgia nahi. Polyarthritis is a major. Arthralgia is a minor. Arthralgia is a minor. I have highlighted it previously. So see how tricky it is. It is a tricky question. The correct answer is is marked by the students who have detailed concept of it. Otherwise, it is a very tricky question. Anyone can do the mistake here. So the correct answer here is A, because arthralgia is a minor criteria, arthritis is a major criteria. So A is the correct answer. Samarth, M, and Nandini are first to answer. Okay, great. So correct answer here is A. So I'm moving ahead. Out of the 5 major, I will discuss all of them. I will start with heart. So the disease in heart is rheumatic heart disease. So there is a pancarditis. These will be the headings in which I will describe it. There is pancarditis in the heart. There is pancard. Can you see this is a heart? In the heart, the wall of the heart, there are 3 layers in the wall of the heart. The innermost layer is endocardium. Can you see? This is endocardium. I'm marking with purple. This is myocardium. I'm marking with yellow. This is all myocardium. Endocardium, myocardium, and outermost is the pericardium. So this is pericardium. I'm marking with red. So endocardium, myocardium, pericardium. All 3 layers are involved in rheumatic heart disease. There is endocarditis, there is myocarditis, there is pericarditis, or I can say there is pancarditis. There is pancarditis. Listen, I would like to tell you one more thing here. So this is the heart. These are the 4 chambers of the heart. These are the walls. These are the walls in the heart. The innermost layer I have told you it is endocardium. So this is the endocardium, endocarditis. The middle layer I have told you it is myocardium. So this is all myocardium. And the outermost layer I have told you pericardium. So this is pericardium. So all 3 layers are involved. I have told you endocardium is of 2 types. Why I am drawing this diagram for you? To tell you endocardium. Endocardium is of 2 types. Endocardium, which I have drawn with purple here. Endocardium, which is lining the innermost layer. It is like a cylinder. No? Heart is a three-dimensional structure. The innermost layer of the heart, that is endocardium. This endocardium is known as mural endocardium. This is mural endocardium. And I have told you previously the heart walls, the walls of the heart, mitral wall, tricuspid wall, aortic wall, pulmonary wall, all walls are also made up of endocardium. So this endocardium is known as valvular endocardium. So endocardium is of 2 types. The endocardium over the walls is valvular endocardium, and except from the walls everywhere else, the endocardium is known as mural endocardium. So both these endocardium are involved. So endocarditis is of 2 types: mural endocarditis, valvular endocarditis. So endocarditis will be of 2 types here. Correct or not? So endocardium will be involved, myocardium will be involved, pericardium will be involved. Say yes or no. Say yes or no. So can you see the diagram? This is the tonsillitis. Child is having tonsillitis. The red colored rods are the bacteria here. The red colored rods are the bacteria. Body is forming antibodies. So antibodies is going to the heart and involving endocardium, myocardium, pericardium. So there is pancarditis. All layers of the heart is involved. So pancarditis I will teach you. So this is the summary which is we are going to learn today at the end of the lecture. So just see this table. We will cover it one by one. First, I will teach you endocarditis. Endocardium is of 2 types. I have told you: mural endocarditis, valvular endocarditis. We will study one by one. Then we will study myocarditis. Then we will study pericarditis. And overall, we will study pancarditis. Now listen one by one. I will be a little bit fast. I have to finish it. Yes. So I'm starting with endocarditis. So endocarditis, maybe first I will teach you valvular, then I will teach you mural. You know the difference now. Valvular and mural, you know the difference. Yes or no? So I'm teaching you valvular. So walls of the heart are involved. So on the walls, small, you know the 4 walls in the heart. What are the 4 walls in the heart? mitral wall, tricuspid wall, aortic wall, and pulmonary wall. These two are semilunar walls. These two are atrioventricular walls. All four walls can be involved due to antigen antibody reaction, not due to bacteria. Again, I am revising you. Due to antigen antibody reaction, these walls are involved. And on these walls, there will be small vegetations. What do you mean by vegetations? You know the meaning of the vegetations. Can you see small dots over the wall? These are the diagrams of the wall. Appreciate the small dots over the walls. So these are vegetations. These vegetations, small vegetations are formed here because of antigen antibody reaction. Own antibodies are destroying the heart walls by causing antigen antibody reaction. These are the live diagrams. Please appreciate these small vegetations. So these are small vegetations over the heart walls. Can you see small vegetations here? So these are all small vegetations formed over the walls. So on the walls, there are vegetations. On the walls, there are vegetations. Vegetations are also known as verrucae. Now describe these vegetation. What is the size? What is the location? Which walls are involved? Tell me the sequence. Which wall is most commonly involved? Which wall is least commonly involved? What is the composition? So tell me all the things about vegetation. On the walls, vegetations are formed. Now tell me the detail of the vegetations. So vegetations are small. There are three sizes: small, medium, large. So here the vegetations are small dots. They are multiple. I have told you the diagram, na? Shown you the diagram also. They are soft and firm. They are soft also, firm also. And they are sterile because vegetations are not formed by bacteria. They are formed by antibodies. That's why they are sterile or bland. Please highlight it. They are sterile. They are sterile. So please see this diagram. Can you see the two walls here? So here I can see a bicuspid wall. I'm marking with purple. This is bicuspid wall. And here it is tricuspid because I can see three cusps. It is tricuspid. Can you see the two walls with purple color I have marked on these walls? Please zoom out and see the yellow colored dots. So yellow colored dots are the vegetations there. So vegetations are formed over the walls. The first diagram is of rheumatic heart disease. I have to teach you 4 endocarditis today. Now, this is the first endocarditis. So this is second, third, fourth. Vegetations will be formed in all types of endocarditis, but the size is different, location is different, wall is different. So we have to see the difference and make a comparative table of it. The 4 types of endocarditis: rheumatic heart disease, infective endocarditis, NBTE, non-bacterial thrombotic endocarditis, and Libman-Sec endocarditis. I have told you now we will study 4 endocarditis today. So we are starting with the first one. So can you see the vegetations in the first one? Look the first diagram only. Don't look the rest. The first vegetations are small. They are not medium or large. They are small. They are multiple. They are multiple. Can you see? They are small, multiple, marked with the arrow. So vegetations, and which wall is most commonly involved? Most commonly mitral wall is involved. Second most common, aortic wall. These are left side walls. Left side में mitral और aortic होता है. And third most common is tricuspid. And least common is pulmonary. So what is the sequence? It is mitral, followed by aortic, followed by tricuspid, followed by pulmonary. So make a mnemonic, MATP. This is the sequence of involvement of walls by vegetations. So vegetations involved in this sequence. It is very important for MCQ. Please mark it. Please highlight it. Mitral, followed by aortic, followed by tricuspid, followed by pulmonary. So 2 MCQ can come. Which is most commonly involved? Answer is mitral. Which is least commonly involved? Answer is pulmonary. Say yes or no. Can we move ahead? Can we move ahead? So that is so most common wall involved. Commonest wall is mitral. Second most common, aortic. Least common, pulmonary. Now I have told you mitral is most commonly involved. Now mitral is most commonly involved. So if mitral wall is involved, most commonly it is involved. So what will happen? In the wall, 2 things can happen now: mitral regurgitation or mitral stenosis. So on the mitral wall, if vegetations are formed, both can happen. Mitral regurgitation can also happen and mitral stenosis can also happen, but more commonly regurgitation will happen. So regurgitation followed by stenosis. So regurgitation will be the most common deformity is mitral regurgitation because of involvement. What is the location on the wall? Now I would like to draw a diagram here. Let me show you a diagram. Okay. Now it is difficult to understand what is the location of the vegetation. Now see, this is the heart. These are the 4 chambers of the heart, and these are the walls. I'm drawing the walls with yellow color. So this is a mitral wall, just for sake, and this is a tricuspid wall, for example. So these are the walls. So this is atria, na? This is left atria, this is right atria, and these are ventricles, right ventricle, left ventricle. So below are the ventricle. So what I mean to say, listen. So this is a yellow colored wall. This is a yellow colored wall. This is a wall. So one surface of the wall is towards atria and one surface of the wall is towards ventricle. Wall aisa hai na? So one surface is towards atria and one surface is towards ventricle. Say yes or no. Can you see the wall here? Wall is like this. One is above surface is towards atria and below surface is towards ventricle. There's a ventricle. There's a wall separating atria and ventricle. Say yes or no. Say yes or no. No, I'm talking about bicuspid wall. So there are two cusps here. In the bicuspid wall, there are two cusps on the left side. So where are the vegetations? Vegetations are over atrial surface or ventricular surface? No, neither on atrial surface nor on ventricular surface. It is at the junction. It is at the junction. That is the location of small vegetations. जो छोटे छोटे दाने हैं, vegetations हैं, वो कहाँ पर हैं? This is the wall. On the wall, where it is? You know, it is most common mitral wall. Okay, I know it. But on mitral wall, where it is? Tell me the exact location on the mitral wall. So it is at the junction. It is at the junction. Listen, where junction? Now, bicuspid wall. What do you mean by bicuspid? There are two cusps. So these are the two cusps. Just suppose these two are hands and these are two cusps. So two cusps are separating. So blood is coming from above to below and they are closing. So they are opening, they are closing. They are opening, they are closing. There is a atria above, there is a ventricle below and blood is pumping out from atria to ventricle during systole. Say yes or no. So it is like this. So vegetations are formed at the line of closure. So here I am marking with pen. So these are the vegetations here and the same vegetations occur here also at the line of closure. So at the line of closure, these are the vegetations, neither on the atrial surface nor on the ventricular surface, at the junction at the line of closure. Can you see the marks? These are the vegetations. So I hope you got it. I hope you got it. If you not got it, just learn it. So where the vegetations are formed, tell me the location. Along the line of closure of the leaflets or the cusp. It is a bicuspid or tricuspid. See. So can you see the first diagram? Can you see? So it is at the junction. All the vegetations are at the junction of the cusp, at the line of closure. So see the first diagram only, not all. See the first diagram. So this is the one cusp, this is the second cusp, and these are the small dots at the line of closure. At the line of closure. Beautiful diagrams from Robbins. So at the line of the closure. So this is a bicuspid wall you can see here. This is a tricuspid wall you can see. Whether bicuspid or tricuspid, it is always present at the junction. It is always present at the line of closure. It is always present at the line of closure. Say yes or no. Give me a thumbs up if you got it. Give me a thumbs up if you got it. So where the vegetations are present, it is present at the line of closure. At the line of closure. Give me a thumbs up. Okay, got it. So that was the location. And because of these vegetations, what is the deformity in the wall? There is a name of deformity. It is known as fish mouth deformity or buttonhole deformity. What do you mean by it? Fish mouth. So can you see it is a bicuspid wall. This is one cusp. This is another cusp. And there is a gap in between. So small vegetations are formed on both. So these are the vegetations on this cusp and these are the vegetations on this cusp. So it is looking like a fish mouth. It is like pouting and fish mouth. So it is known as fish mouth appearance. So tell me what is the appearance? It is cute now. So it is known as fish mouth appearance. So or buttonhole appearance. Look at this diagram also. Again looking like a fish mouth. You can see the two cusps. This is first cusp. This is second cusp. And you can see the small vegetations over here. Small vegetations you can appreciate if you zoom it out. So these are the vegetations looking like a fish mouth or buttonhole. Give me a thumbs up. Again fish mouth or buttonhole. Again fish mouth. You can see a fish mouth here. So fish mouth or buttonhole. Take these two words. So fish mouth and buttonhole appearance. So we are done with the vegetations. So which is the most common wall involved? Tell me. It is mitral wall. And what will happen in mitral wall? If it is acute rheumatic fever, it is regurgitation. If it is chronic rheumatic fever, it is stenosis. Overall, most common deformity is regurgitation. And least commonly involved wall is pulmonary wall. I have already told you. So we are done. We are done with the vegetations. We are done with the vegetations. Now, can you see this diagram? What is this diagram? What is this diagram? This is one of the cusp of the wall. The wall have two cusps, not two or three cusps. This is one of the cusp. This is one of the cusp, and at the line of junction, this is a vegetation. This is the vegetation. So on the cusp, this is atria. Upar atria hai. Niche there is ventricle. So above there is atria, below there is ventricle. At the junction of it, there is a cusp. There is a cusp leaflet, and on that vegetation is formed. On that vegetation is formed. So this is a diagram from Hirschman. So on wall, on valvular endocarditis, we are studying endocarditis. On valvular endocarditis, vegetations are formed. Vegetations, write everything about vegetations. They are soft, they are firm, they are small, they are multiple, they are formed over mitral wall, and they are most common at the junction. And deformities, fish mouth or buttonhole, write everything about vegetation. On all the things they are sterile, yes, and they are on all the things there is one MCQ. So just write everything about vegetation, you know. So that is about valvular endocarditis. Now I'm coming on the second endocarditis, that is mural endocarditis. That is mural endocarditis. Now listen. So this is a heart. These are the four chambers of the heart, and this is the mural endocardium. Mural endocardium, not valvular. I am talking about mural. Except wall, the rest of the endocardium is mural endocardium. So it is a 3D. You have to imagine it 3D. I can't draw 3D now. So it is like a cylinder. So the inner lining of the cylinder is mural endocardium. So what will happen there? Due to antigen antibody reaction, what will happen there? On the walls, vegetation are formed. We are done with it. What will happen at rest of the endocardium? What will be formed there? So this is the left side of the heart. Just for say, this is the left atrium. This is left ventricle, left side, and this is mitral wall in between. This is mitral wall. So on the left atria, just above the mitral wall, a patch is formed. A patch is formed on the mural endocardium. On the mural endocardium, on the left side, in the left atria, just above the bicuspid wall, mitral wall, a patch of wrinkling patch is formed. This patch is known as McCallum patch. So here a patch is formed which is known as McCallum patch in mural endocardium. So a McCallum patch is formed where? Tell me where it is formed. Tell me the exact location. It is formed on the endocardium. Which endocardium? Mural endocardium. In the left atria. In the left atria, just above the posterior leaflet of the mitral wall. And on the posterior wall. Yes or no? So that is a thing. So that is known as McCallum patch. Now see this beautiful diagram from the Hirschman on the posterior wall. Yes, Sanjana. So see this diagram. In this diagram, both endocardium are shown. Mural endocardium, that is McCallum patch, is also shown in this diagram, and valvular endocardium, vegetations are also shown. Both these things are shown by yellow color. Just zoom it out and see. So can you see a patch here? I am drawing with purple. So this is McCallum patch. Can you see it is on the left side? It is in the left atria, just above the bicuspid wall, on the posterior wall. So that is McCallum patch. And can you see the small vegetations here on the wall? The dots here. So that is the thing. So we are done with it. So where is McCallum patch here? It is in the left atria here. Left atria, just above the bicuspid wall in the posterior surface. So we are done with endocarditis. So in endocarditis, if you ask about valvular endocarditis, vegetations are formed. And if you ask about mural endocarditis, McCallum patch is formed. You should know exact location of McCallum patch. It is left atria. Again and again, I'm saying you. Again, important MCQ. On each and every line in my notes, there is an MCQ. Whatever in my notes I have marked with red and blue, it is an MCQ. So just read my notes thoroughly. Make your own notes after reading my notes and take whatever I have marked with red and blue. Correct or not? So we are done with endocarditis. I'm coming on myocarditis. Any doubt in endocarditis? Endocarditis is of two types, valvular, mural. In valvular, there are vegetations. Write everything about vegetations. And in mural, there is a patch which is known as McCallum patch. Correct or not? Coming on myocarditis. Give me a thumbs up if you got it. Coming on myocarditis. Okay, done. Okay. So coming on myocarditis. So what will happen in myocarditis? So again, I would like to draw a heart here. So this is endocardium. This is endocardium here. I'm not concerned with endocardium. This is mural endocardium. This is valvular endocardium. I'm not teaching endocardium now. So I'm coming on myocardium now. This is myocardium marked with blue. And this is pericardium. I'm concerned with myocardium. In the myocardium, multiple small granulomas are formed. Mind my words. Multiple small granulomas. Yes, you have heard it correctly. Granulomas are formed. So multiple small nodules or granulomas are formed. These are known as Ashkoff bodies. Ashkoff. Just maybe the spelling is incorrect. Just look the spelling what it is. Ashkoff bodies. Ashkoff bodies. So in myocardium, multiple small nodules or granulomas are formed, which are known as Ashkoff bodies. So what is the composition of them? I will tell you the composition. See, so Ashkoff bodies are formed in myocardium.
Now, these Ashkoff bodies are pathogmatic. They are formed only in one disease, rheumatic heart disease. Nowhere else in this world, no other disease. So they are make a star over it. They are pathogmatic for the disease. So these vegetations are formed in many diseases. McCallum patch, maybe they are in other diseases also, but Ashkoff bodies are pathogmatic. They are pathogmatic for rheumatic heart disease. Again, a very important MCQ. So what is the pathogmatic feature for rheumatic heart disease? It is Ashkoff bodies which are present in myocardium. What are Ashkoff bodies? They are small granulomas. They are small granulomas. They are present in myocardium. They are present in myocardium. So can you see, this is myocardium. In the myocardium, small dots are present. They are granulomas. They are granulomas. So what is the composition? So let me zoom out one of the Ashkoff body. If I take one of the, if I cut here, take one of the Ashkoff body separately and make a slide of it, look under microscope. What is the composition? What are the cells which composite this body? So Ashkoff body, I am making one of the Ashkoff body. So in the center, there is necrosis. In the center, there is necrosis, which is fibrinoid necrosis. You know the 5 type of necrosis: coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis. Last one is fibrinoid necrosis. So in the center of the Ashkoff body, all the Ashkoff bodies, there is fibrinoid necrosis. Never forget, it is fibrinoid. And surrounding this necrosis, there are 5 type of cells. 5 type of cells. What are those 5 type of cells? Some of them are Ashkoff cells. I'm drawing with green. Ashkoff cells are giant cells containing multiple nuclei, multinucleated giant cells. They are Ashkoff. Ashkoff body में Ashkoff cell होते हैं. Ashkoff cells. Some of them are anti-Ashkoff cells. I'm drawing with red. Some of them are anti-Ashkoff cells. Anti-Ashkoff cells are macrophages which have caterpillar-like nucleus, either caterpillar or owl eye, ullu ki aankh. So some of them have caterpillar-like nucleus, some of them have owl eye appearance. So this is the second cell. And third cell are lymphocytes. You all know what is lymphocytes. Some of them are lymphocytes, some of them are plasma cells. You know what are plasma cells. Some of them are plasma cells and some of them are fibroblast. Outermost are fibroblast. So this is the composition. So center contains necrosis surrounded by 5 type of cells. Name 5 type of cells. What are the 5 type of cells? Tell me. It is Ashkoff cells. It is anti-Ashkoff cells, anti-Ashkoff cells, lymphocyte, plasma cells, and fibroblasts. These are not important. Important one are Ashkoff and anti-Ashkoff. Ashkoff and anti-Ashkoff both are macrophages, modified macrophages. Ashkoff and anti-Ashkoff both are modified macrophages. Only difference is the nucleus. Ashkoff cells has giant cells, multinucleated, and anti-Ashkoff is caterpillar or owl eye appearance. So I will show you the diagrams here. So this is a diagram of the granuloma. Can you see? The center contains fibrinoid necrosis, yellow colored fibrinoid necrosis, and surrounded by 5 type of cells. You know Ashkoff cells and you know anti-Ashkoff cells. So look at anti-Ashkoff cells here. The diagram from Hirschman. Can you see here? So one is caterpillar appearance and other is owl eye appearance. Caterpillar appearance and owl eye appearance. So center is the fibrinoid necrosis surrounded by 5 type of cells. Ashkoff and anti-Ashkoff are important. Ashkoff and anti-Ashkoff are important here. There are no neutrophils. In these 5 cells, neutrophils is absent in this granuloma. So what are Ashkoff cell? What are anti-Ashkoff cell? Both of them are macrophages, modified macrophages. Ashkoff cells are giant cells. Anti-Ashkoff cells have caterpillar cell or owl eye appearance. Say yes or no. Give me a thumbs up if you got it. So that was all about the composition of the granuloma. So see it, how it looks actually under microscope. So zoom it out. Can you see it is a giant cell? Yes, it is a Ashkoff cell. Can you see these cells? This one and this one. These 2 are anti-Ashkoff cell. One is having caterpillar appearance. Other is having owl eye appearance. So you have to take these sketchy words for MCQs. So these are the real diagrams. These are the real diagrams showing it. So can you see this is a caterpillar cell? Again, this is a caterpillar. All of them are caterpillar cells. So these are anti-Ashkoff cells, caterpillar appearance. So that is the thing. So we are done with endocarditis. We are done with myocarditis. In myocarditis, you have to take only one word. In the myocardium, granulomas are formed. The name of the granuloma is Ashkoff body. And Ashkoff body is made up of 5 type of cells. You know the name of the 5 type of, and center contain necrosis. Which necrosis? fibrinoid necrosis, and surrounded by cells, 5 type of cells. What are the 5 type of cells? You know, the two are important: Eshkov, anti-Eshkov. Both of them are macrophages. You know the nucleus of them. And neutrophils are absent. Neutrophils are absent. We are done with myocarditis. Should I come on pericarditis? Give me a thumbs up if you got myocarditis. Any doubt in myocarditis? Should I come on pericarditis? Give me a thumbs up. I want everyone to participate. It is not bhajan kirtan, no. You are just listening. Like, you have to be interactive, no. If you are learning it, you have to ask your doubt if you have any doubt. If you don't have any doubt, give me a thumbs up so that I can proceed. So there is a difference in watching recorded lecture and watching live lecture, no. So Unacademy platform is giving you benefit of live. Live is live, so you can always have interaction with me. So I will try to address it. So Prabhakar is asking PSG, and I will come on PSG in my next lecture, Prabhakar. Don't worry. So yeah, it is related of heart, kidney will be involved. So here only pharyngitis was there. There pharyngitis and skin infection both will be there. So both are related. Don't worry, but I will definitely cover it. Don't worry. So just wait. Okay. So coming on the third thing, that is pericarditis. So we are done with endocarditis, myocarditis. Now coming on pericarditis. What is pericarditis? So again, I will draw the heart. So these are the 4 chambers. This is the endocardium. Not concerned with endocardium now. This is the myocardium. I'm not concerned with the pericardium here. The outermost layer of the heart is pericardium. Pericardium, so there is a gap between myocardium and pericardium. This gap is known as pericardial gap, pericardial sac. This gap is known as pericardial sac, and it contains a fluid which is known as pericardial fluid. Normally, this fluid is watery. It is like watery fluid. Thin watery fluid is there in all of the normal. In you, in me, it is present. Pericardial fluid. It is in very minute amount. Pericardial fluid. But if antigen antibody reaction is taking place here in rheumatic heart disease, group A beta streptococcal bacteria infection, so if it is happening there, this watery fluid will get converted into fibrinoid. It will get converted into fibrinous fluid. What do you mean by fibrinous? Watery to samajhta hai, it is like water. What do you mean by fibrinous fluid? Fibrinous is thready, like thread. Have you seen like thread? Fluid containing threads, dhage jaisa. It will be like thready fluid. So this watery fluid will get converted into fibrinous fluid. So it will contain fluid like threads. So it is known as fibrinous pericarditis. So just suppose if a child is dead of rheumatic heart disease, I am doing the postmortem of the child. So I am taking the heart out. So once I will take the heart out of the body of the child, I am giving a cut in it. I'm giving a cut in it and just opening it, just opening the pericardial fluid. I'm giving a cut here. I'm giving a cut here and just opening I'm separating the pericardium from myocardium. So उन दोनों के बीच में I can see the fibrinous fluid. So how it will look? So the two layers will be separated और उन दोनों के बीच में धागे होंगे. So have you ever eaten a butter sandwich? Yes, every one of you, I guess. So this is one slice of bread. This is another slice of bread, and between them, if you try to separate the two slices of the bread with a butter in between, so you can see threads in between, the thready butter. So that is known as bread butter appearance. So it will look like this. So if I cut so can you see the pericardial fluid containing the fluid that is fibrinous? So I'm cutting it with a scissor. I'm cutting the pericardium with a scissor, and can you see I'm separating it from the myocardium? I'm separating so can just appreciate. Please see this diagram. See it. Just appreciate the threads in between. Can you see the threads here? So I'm separating pericardium from myocardium. I can see the threads. So that is fibrinous pericarditis. That is known as bread and butter appearance. Take this word. Bread and butter, fibrinous pericarditis. So I'm done with pericarditis also. So that is my summary till now. So Udit is asking, fibrinous morphology is inflammatory in Robbins. Yes, it is inflammatory. You can say it is not purulent, Udit, but it is inflammatory. Now, inflammation to hai, but it is due to autoantibodies, not due to bacteria. Inflammation is due to autoantibodies. It is not due to bacteria. It is inflammatory. Yes, you can say. So pancarditis, I'm done with it. So pancarditis, endocarditis, myocarditis, pericarditis. In endocarditis, there is valvular endocarditis, mural endocarditis. In valvular endocarditis, there is vegetations. In mural endocarditis, there is McCallum patch. In myocarditis, there is Ashkoff bodies. In pericarditis, there is fibrinous pericarditis, that is bread and butter appearance. Say yes or no. Say yes or no. So we are done with it. So I would like to launch some polls here. Are you people ready for the polls? Give me a thumbs up if you're ready for the polls. What you can do now, you can draw one diagram. I'm not drawing it. You can draw one diagram here showing all the three layers. That is endocardium, myocardium and pericardium. Endocardium, draw it with different colors. Endocardium, myocardium, pericardium, and draw all the changes which I have told you here only. So in the endocardium, draw the vegetations, draw the McCallum patch. In the myocardium, draw the Ashkoff bodies, and in the pericardium, draw the fibrinous fluid. You will never forget. This will be your master diagram of rheumatic heart disease. So that is the summary till now. I would like to launch some polls here. There are many polls, nearly 10-15 polls. So those who are preparing for the competitive exam, these polls are really important for them. So I guess all of you are preparing. Either you are an intern or you are a second prof student, whatever you are preparing for some or the other competitive exam. Either it is NEET PG, FMGE, NICT or next. So whatever it is, the questions will be same. The questions will be same. You should have a practice for previous year questions. So I have covered all previous year questions, especially from the past 5 years of all these exams. So I would like to launch them. Are you people ready? Should I launch it? So I will give you only 15 seconds and I want everyone to participate. At max, you will be wrong, na? Chalega, but you should participate. Okay, so this is the first question in front of you. Just read it. Just read it. I will launch it. A 10-year-old boy. Look at the age. 10-year-old boy. So he's a child. Pappu died of rheumatic fever. So what we can expect at autopsy, except, question contains except. So what will not be seen in the heart of the patient at autopsy? Not seen, because question contains except. Patient is having rheumatic fever. So Ashkoff nodules will always be there. Ashkoff nodules will always be there. Yes, in the myocardium, McCallum patch will be there. In the mural endocardium and fibrinous pericarditis will be there. These three things will be there, but rupture of chorda tendineae, it is not a feature of rheumatic fever. So correct answer here is B, and most of you are correct. Okay, good. You can see the leather board. So correct answer here is B. So I'm done with it. This is the next question in front of you. Okay. So anti-Ashkoff cells are. Anti-Ashkoff cells are. I have told you in the Ashkoff bodies, granulomas, two types of cells are there, Ashkoff cells and anti-Ashkoff cells. Both of them are what? I have told you already. Yes, most of you are correct. Only difference is nucleus, but both of them are macrophages. They are modified macrophages. In Ashkoff cells, nucleus is multinucleated. It is a giant cell. And in anti-Ashkoff cell, the nucleus is caterpillar shape or owl eye appearance, ulluki aankh, owl eye appearance. Say yes or no. So the correct answer here is A. And most of you are correct. The correct answer here is A. This is the next question in front of you. You can see which is not seen in Ashkoff bodies. In the composition of Ashkoff bodies, which cell is absent? Which is not seen? I have told you 5 type of cells in Ashkoff bodies. 5 type of cells are present. Ashkoff cell, anti-Ashkoff cell, plasma cell, lymphocyte and fibroblast. Which is not present? I have told you neutrophils are absent. Neutrophils are polymorphonuclear cells. The other name of neutrophils is PMN, polymorphonuclear cells. Yes or no? So neutrophils are absent. Fibroblasts are present. Ashkoff cells are present, and Ashkoff cells are giant cells only. Ashkoff cells and giant cell is one and the same thing. I have told you, Ashkoff cells are modified macrophages, which are giant cells. So one and the same. It is present. So the correct answer here is D. It is absent. It is absent. Neutrophils are absent. Most of you are correct. Maya Bhav, Shrishti and Sheikh are first to answer. I forget to announce the names every time. So just forgive me for that. You can see by yourself on the leather board. So correct answer here is D. Correct answer here is D. I'm coming on the next question. This is the next question in front of you. Most common wall involved in rheumatic fever. Which is the most common wall involved? Yes. I want everyone to be correct. 100%. जो इसमें गलत होगा ना, I will slap you. So, most common wall involved in rheumatic fever? Yes. Which wall is involved most commonly in rheumatic fever? So, most common wall involved is mitral, followed by aortic, followed by tricuspid, followed by pulmonary. So, this is the MATP, is the sequence. So, the correct answer here is A. So, Priya, Sushma and Yashika are first to answer. Good girls. Okay. The correct answer here is A. So coming on the next question, this is the next question in front of you. Yes. Wall which is not involved in rheumatic fever. Not involved or least common, you can say. So which wall is least commonly involved or not involved? One and the same thing. Itna least ki it is not involved. So which wall is not involved in rheumatic fever? I have told you the sequence. So mitral followed by aortic, followed by tricuspid, followed by pulmonary. So the correct answer here is pulmonary. And most of you are correct. Correct answer here is C. Pulmonary is least commonly involved. Yes. So the correct answer here is C. Coming on the next question. Ashkoff bodies are seen in. Ashkoff bodies are seen in. Which layer? Endocardium, myocardium, pericardium. Yes, rheumatic to hai, everyone knows. So it is seen in rheumatic myocarditis, not in endocarditis. It is seen in myocardium and rheumatic fever. So most of you are correct. The correct answer here is A. Ashkoff bodies, that is granulomas, are seen. So granulomas are seen in rheumatic myocarditis. Correct answer here is A. This is the next question. McCallum patch is diagnostic of what? McCallum patch. Yes. McCallum patch kahan par hai? McCallum patch was present in mural endocardium. So McCallum patch is diagnostic of which disease? अभी तो ये क्वेश्चन बहुत इजी लग रहा है. Everyone knows यार rheumatic एक ही disease तो पढ़ाया है मैम ने. So correct answer is B. But when you study infective endocarditis, MI, TOF, then this question will be confusion. It will create confusion. So the correct answer here is rheumatic endocarditis. Everyone knows the correct answer. So the correct answer here is B. Everyone knows it. I know. So, okay, I have not launched the poll. Okay, sorry. It's okay. So correct answer is B. Everyone knows it. Na? Okay. So the correct answer here is B. I forgot to launch it. So this is the next question. Characteristic feature of rheumatic carditis is. Yes, what is the characteristic feature of rheumatic carditis? It is endocarditis, myocarditis, pericarditis, or pancarditis. What is the characteristic feature? Yes? Why you people are wrong? Correct answer here is pancarditis. No, I have told you in rheumatic carditis, it is pancarditis. All three layers are involved. Endocardium, myocardium, pericardium, all of them are involved. So pancarditis is the characteristic feature. No? So the correct answer here is D. Correct answer here is D. Why you got confused? If you have any doubt, you can write in chat. If you have any doubt. Correct answer here is D. It is pancarditis because in rheumatic fever, all layers are involved. That is pancarditis. Say yes or no. This is the next question in front of you. Yes. The most histological finding, most characteristic histological finding in rheumatic carditis. Most characteristic I am asking. All of them will occur. But what is the most characteristic, or you can say pathogmatic? I've told you what is pathogmatic. Most characteristic or pathogmatic क्या है? होगा तो सब. Everything will happen. But what is most characteristic? Fibrinous pericarditis happens, but it is not characteristic. Vegetation occurs, but it is not characteristic. Increased vascularity occurs, but it is not characteristic. Characteristic is Ashkoff bodies, which is pathogmatic feature. Make a list of pathogmatic feature from the Robbins. All the pathogmatic features of all one place. So make a table of it. So pathogmatic feature of rheumatic heart disease is Ashkoff bodies. होता तो ये सब है. But the pathogmatic is C. So the correct answer here is C, and most of you are incorrect. I don't know why. Most of you have marked as B as correct answer. Why vegetation? Vegetation तो इतने सारे disease में होते हैं. Vegetation occurs in many disease. How it can be characteristic? Characteristic तो वो होगा which occurs in this disease only. So it is the Ashkoff body. Nowhere else Ashkoff body you will find. You will find Ashkoff body only in rheumatic heart disease. Say yes or no. So the correct answer here is C, not B. Those who have marked B, have you got it? Why the answer is not B? It is C. You should know the reason also. For everything, there is a reason in this world. So you should know the reason. So the correct answer here is C. Say yes or no. So this is the next question in front of you. Exudate in rheumatic fever. What is the exudate in rheumatic fever? By exudate, I mean pericardial fluid. Pericardial fluid में कौन सा fluid भरता है? So all of you are correct. It is fibrinous, thready fluid. So exudate in rheumatic fever is fibrinous. Correct answer here is C, and most of you are correct. Okay, I'm happy you got it. So the correct answer here is C. Coming on the next question. This is the next question in front of you. Pathogmatic feature. Pathogmatic feature of rheumatic fever. Again, a repeat question. Pathogmatic feature. Rut low. Just mug up.
So what is the pathogmatic feature? Most of you are correct. Okay, good. So the correct answer here is D, Ashkoff nodules. It is not pericarditis, not myocarditis, not mitral stenosis. Pathogmatic feature is Ashkoff nodules, which means granulomas in the myocardium. So the correct answer here is D. Correct. So correct answer here is D. Coming on the next question. This is the, okay, I will skip this one. So this is the next question. Yeah, very easy. Everyone should participate. McCallum patch is seen in which chamber? There are 4 chambers in the heart, no? Right auricle, right ventricle, left auricle, left ventricle. McCallum patch kahan hota hai? Where it is present? In which chamber? So most of you are correct. It is present in left atrium. In left atrium. Correct answer is B. So it is present in left atrium, just above the bicuspid wall, on the posterior wall, on the posterior surface. So you should know it correctly. So the correct answer here is B. Most of you are correct, but some of you are incorrect also. I don't know why. I've told you so clearly, still you people are incorrect. So it really hurts to me. So you should be attentive during the lecture. If you are attending a lecture, you should be attentive. Otherwise, don't attend now. Just exit. Nobody is doing any compulsion to you now to attend the lecture. So if you are attending, it is for your benefit, not for my benefit. So you should be attentive and you should be correct. So correct answer here is B. Correct or not? So this is the next question in front of you. Yeah. Just read it. Don't rush. It is a tricky question. In rheumatic fever, fibrinoid necrosis is seen in which layer? Endocardium, myocardium, pericardium, where it is present? Fibrinoid necrosis in rheumatic fever. Now, most of you are incorrect. मैंने बोला था ना tricky question है, don't rush. I have told you previously it is a tricky question, don't rush. Most of you are incorrect. Most of you have marked pericardium as the correct answer, but it is not a correct answer. So those who correct answer is A, myocardium. I am not asking fibrinous pericarditis, bread and butter. I am not asking that. So you have marked pericardium by mistake. I am not asking fibrinous pericarditis. I am asking fibrinoid necrosis. So fibrinoid necrosis was present in granuloma. At the center of the granuloma, the yellow colored necrosis was fibrinoid necrosis in Ashkoff bodies. And Ashkoff bodies are present in myocardium, not pericardium. So you got confused with the word fibrinoid. You got confused. You have confused fibrinoid with fibrinous. So that is fibrinous pericarditis. That is a separate thing. Fibrinoid necrosis, that is a separate thing. Have you got it or not? Correct answer here is A, myocardium. Because in myocardium, Ashkoff bodies are present. And in Ashkoff body, it is granuloma. And the center of the granuloma has fibrinoid necrosis. Say yes or no. Say yes or no. Have you got it? So the correct answer here is myocardium. The correct answer here is A, myocardium. Say yes or no. So those who have marked A, they are correct. And those who have marked C, they are incorrect. So I'm done with the MCQ till now. So out of the 5 major criteria, Jones criteria, we have already covered rheumatic heart disease. So the rest of the 4 are, I will not take in detail. I will tell you only important points about rest 4 Jones criteria. So we will talk about them. These 4 are known as extra cardiac lesion. So we will take them one by one. First, I will tell you about polyarthritis. Then I will tell you about syndrome scoria. Then I will tell you about erythema marginatum. Then I will tell you about subcutaneous nodules, and I will launch polls based on all these 4. They are small, don't worry. So first I will take migratory polyarthritis. That is joints are involved. That is the earliest manifestation in rheumatic fever. सबसे पहले ये होता है out of the 5. That is the earliest manifestation, and it is the most common manifestation also. Out of the 5, this is the most common. Out of the 5, this is the earliest. Here, large joints are involved. Small joints are not involved. Mother will come to you taking the child and say, my child says his shoulders hurts. His hips hurt. Small fingers do not hurt. Shoulder, elbow, wrist, larger joints hurts. Larger joints are painful. The joints are hot, red, swollen, and pain. Extremely painful. You will touch the child at the joint. Child will shout on you. No, it is painful. So it is extremely painful. If you touch the joint, it is hot, red, swollen, it is inflamed. So, and pain is out of proportion, too much painful. So that is the thing. And it is migratory. Mother will say, child will say, sometimes I am having pain at the shoulder. Sometimes shoulder is okay, but pain at the elbow. Sometimes pain at the elbow is okay. It is not painful. Sometimes it is in the hip. That is, it is migratory. दर्द यहाँ से वहाँ घूमता है. It is migratory. Pain is migratory. Say yes or no.
So sometimes it is in the ankle, sometimes it is in the knee, sometimes it is in the elbow. That is multiple joints are involved. And it is migratory. It is migrating from one joint to another, but it is non-erosive. It is not like rheumatoid arthritis. It is not erosing the joint. It is non-erosive. Please take it. And a single dose of aspirin will treat it. Pain will be disappeared. So you will ask the mother to give one tablet of aspirin. A single dose of aspirin or salicylate will do a dramatic response in the pain. That is the thing. So that will be diagnostic, and it is non-deforming. Deformity nahi hogi koi. It is non-deforming, non-erosive. It is the earliest feature. So we are done with all important points about polyarthritis. What you have learned: multiple joints are involved. It is migratory. Larger joints are involved. It is painful. Single dose of salicylate will subside the pain. Yes or no? These are the important points. Write all important points here. So that is polyarthritis. Yes or no? Coming on the next, that is syndrome scoria. Syndrome scoria. It is also known as St. Vitus dance. The other name for syndrome scoria is St. Vitus dance. So can you see the child here? Why the child is dancing? Can you see the child is dancing? Can you see the child is dancing? No, actually child is not dancing. The brain of the child, in the brain caudate nucleus of the child, in the brain caudate nucleus of the child is involved by antigen antibody reaction. It is damaged. So caudate nucleus is damaged. So child is doing purposeless movements in the air, irresistible, involuntary purposeless movements in the air, jerky movements. So it is looking like child is dancing, but actually it is not dancing. Child is having caudate nucleus damaged. So that is known as syndrome scoria. Syndrome scoria. Why it is known as St. Vitus? St. Vitus is the name of the first child which is involved by this disease. So St. Vitus is the child here. So the first patient, the name of the first patient is St. Vitus. So it is known as St. Vitus dance. It is not very common. It involves 10 to 15% of the patients with acute rheumatic fever. And it is more common in girls, prepubertal girls, and it is a long latency period. So just take the points. Now brain is involved now, so there will be two types of symptoms: neurological and psychological. If brain caudate nucleus is involved, so neurological and psychological, two types of symptoms will be there. Parents will say, child do jerky movements in the air. My child does jerky movements, irresistible movements in the air. But when the child is awakened during sleep, there are no movements. Child sleep like anything, and there are no movements, jerky movements during sleep. They disappear during sleep. So this is the typical history given by the parents for the child. Number one, that is neurological. And psychological, child is emotionally labile. Sometimes child laughs, sometimes cry. At the same time, he's laughing, he's crying. That is emotionally lability is there, separation anxiety is there, OCD is there. So that is psychological symptoms. So that is the symptoms. And there are spontaneous purposeless movements in the air, which I have told you. Now how you will confirm it? You are a doctor, child is present in front of you in your clinic. How you will confirm it? History is given by the patient. Child is doing purposeless movements in the air and they disappear during sleep. And child is having psychological symptoms also. So you have a suspicion child is having syndrome scoria. How you will confirm it being a doctor? You will give your finger to the child and ask the child to hold your finger. Ask the child to hold your finger like this. So you will give your finger, your thumb to the child and ask the child to hold it. So if the child is normal, he will hold it like this, like constant contraction. But if the child is having syndrome scoria, he will not constantly hold it. He will contract, relax, contract, relax, contract, relax. This is known as milk-maid grip. गाय का दूध कैसे निकालते हैं? You know how the milk from the cow is taken out. So it is known as milk-maid grip. Milk-maid grip. So the grip of the child is milk-maid. So take this word. So irregular contractions of the muscles of the hands while squeezing the finger. So if you ask the child to squeeze the finger, there will be irregular contractions. That is milk-maid grip, number one. So that is diagnostic. Number two, you will ask the child to extend the arms. Arms ko extend karo like this. This is milk-maid grip. This is like this. So extend the arms. You will ask the child to extend the arms. When you ask the child to extend the arms, it will be automatically pronated. Supination nahi kar payega. Child will unable to do the supination. Child will do the extend the arms and pronation only. So there will be pronation and spooning of the hands while extending the arms. You ask the child to take the tongue out. I don't have picture of it. To take the tongue out. If the child is normal, he will take the tongue out like this. But if the child is having syndrome chorea, he cannot hold the tongue out at the same place. So he will do like this. He will do that is known as Wormian movements, Wormian darting movements of the tongue upon protrusion. So these, and you can see the parents will say handwriting of the child is changed from some days. From some days, the handwriting of the child is changed. So these are the 4 diagnostic clinical features of syndrome chorea. So milkmaid grip, on extending, there is pronation and spoonation, Warmerian darting movements of the tongue, and handwriting is changed. So these are the 4 clinical features. Say yes or no. Have you got it? Have you got it? Have you got it? What is the treatment? It is a self-limiting. Just reassure the parents your child will be okay after 6 months. After 6 to 12 months, yeah, no, I know it is looking like a dangerous thing, but it is self-limiting disease. It will be okay by itself. Or else, if it fails to be treated by itself, then you can give valproate. And again, if it fails, you can give steroids. And in the end, you can try IV immunoglobulins you can try. So that is the treatment. We are done with rheumatic heart disease. We are done with polyarthritis. We are done with syndrome chorea, the 3rd disease. I am coming on the 4th disease now. The 4th disease is erythema marginatum of the skin. Erythema marginatum of the skin. It is very rare. Only 3% of the patient are involved. It is very, very rare. The skin is involved. The child's skin is involved. Now, can you see the lesions over the skin? Can you see the lesions over the skin? Yes, how it is described them. How it is? Tell the color. The color is red. Erythematous. The color is red. Red means erythromatous. It is erythromatous. It is serpentine. Serpentine like means it is like snake. So it is looking like snake, no? Snakes. So serpentine. Erythromatous serpentine. Macular lesion with a, can you see the pale center? The center of everything is pale. So it is erythromatous, pale center, serpentile. It is non-pruritic. Khujli nahi hai. Pruritic means itching. You will ask the parents whether the child is having itching. No, itching is absent. So mind it, it is non-pruritic. And where it is present? It is present over trunk and extremities, not on face. Look in the diagram. I have shown the trunk. I have shown the extremity. I have shown the extremity. I have not shown the face. It is absent on face. So take these words. So it is erythromatous, serpentile, pale center, non-pruritic, absent over face, and the distribution is bathing suit. Bathing suit. In a swimming pool, you wear a bathing suit, na? Bathing suit in a swimming pool. So the distribution of the rash is like bathing suit. You don't wear bathing suit over face, na? So it is absent over face. It is present over the trunks and extremities. It is present. So that is bathing suit distribution. Take this word. So, and again, it is migratory. Like arthritis, it is migratory. And there is no scarring in the end. It will subside. There is no scarring in the end. Like chicken pox, there is no scarring. No scarring. Non-pruritic. So we are done with erythema marginatum. Tell me all important points. It is erythromatous, pale center, serpentile, non-pruritic, non-itching, no scarring. So write all the points. So we are done with erythema marginatum. Give me a thumbs up if you got it. Should I come on the last one? Last one is subcutaneous nodules. Subcutaneous nodules are there. So small nodules are formed. Can you see this small nodule near joints on the extensor surface? On the extensor surface, not flexor. Can you see it is extensor surface? Small 1 centimeter nodules are formed which are painless. Pain nahi hai isme. So small 1 centimeter nodules are formed on the extensor surface near bony prominences. So it is a bony prominence के पास में यहाँ पे बनेंगे small nodules and they disappear spontaneously. So we are done with it. We are done with all the 5 things, all the 5 major criteria: carditis, syndrome chorea, erythema marginatum, subcutaneous nodules, and migratory polyarthritis. Done? Give me a thumbs up. Should I launch polls based on it? So we are done with rheumatic fever after it. And the diagnosis and treatment part is remaining. We are done with the 5 major criteria. Yes? So should I launch the polls? Okay. Ready for the polls now? So this is the first poll in front of you. Just read it. The question contains except. All are true about arthritis of rheumatic fever except. So what is the correct answer? Just mark it. Polyarthritis and rheumatic fever. What is absent in that? Because the question contains except. Yes? So the correct answer here is D. Most of you are correct. It is non-deforming. It is correct. It is associated with raised ASO. Yes, because it is rheumatic fever. So supporting criteria yaad karo. Gas criteria. So ASO titer will be raised. It will last for 3 to 6 weeks in untreated cases. It is also correct. But small joints are involved. No, it is wrong. I have told you larger joints are involved. Small joints are not involved. So this is incorrect. And since accept is asked, this is the correct answer. So correct answer here is D. Correct answer here is D. Any doubt in this? Should I proceed? Okay. So this is the next question. All are true about subcutaneous nodules in rheumatic fever except. फिर से क्वेश्चन में एक्सेप्ट है. Please mind it. The question contains except. Subcutaneous nodules. I've told you subcutaneous nodules in the last. So most of you are correct. Okay. So, delayed manifestation, yes, it is delayed. Commonly associated with carditis, yes. It is seen in 3 to 5% of the patient, yes. But it is painful, no. It is incorrect. It is painless. I have told you these small nodules which are formed on the extensor surfaces, these are painless. So painful hai, ye galat hai. It is wrong. And since accept is asked, this is the correct answer. So correct answer here is B. Any doubt in this? So sometimes you know the correct answer. So you can mark it by confidence. Sometimes by looking at the option, you know what is incorrect. What is incorrect. So you can do like that. So MCQ karne ki there are two ways. Either you know what is correct, either you know what is incorrect. So you can both ways you can attempt an MCQ correctly. So these are tricky questions. I don't know rest of the three options, but I know B is wrong. It is not painful, it is painless. I know that. So I can attempt the MCQ. Na? I don't know about the rest of the three options. So the correct answer here is B. Okay. So this is the next question in front of you. All are true about erythema marginatum except. Again, the question contains except. Please read the options. Question contains except. Question contains except. Again. All are true about erythema marginatum except. Yes, most of you are correct. So pruritic is wrong. It is non-pruritic, non-itching. Khujli nahi hoga. I have told you. Bathing suit distribution, it is right. Earliest manifestation, it is right. Seen rarely, it is right. But it is non-pruritic. It is not pruritic. It is non-pruritic. And since accept is asked, so this is the correct option. So correct answer here is C, and most of you are correct. So that is the thing. So this is how MCQs comes in your exam. The tricky one. You should know the concept. Now you should do past 5-year or 10-year MCQs of whatever exam you are targeting. If you are targeting NEET PG, FMGE, NICT, you should do past 5-year questions of all these exams. That is a repeat question. Now, any paper, if you are targeting for NEET PG especially or FMG, any paper contains 50% repeats and 50% new. But the students who are selected, they are prepared for repeat also, for new also. Most of the students are prepared for repeat, but they are not prepared for the new. For preparing for the new MCQs, you should read the theory thoroughly. You have to do the previous year MCQs. That is for repeat preparation. But what about the new MCQ? 50% MCQ will be new. It won't be repeated from the previous year. It will be new MCQ. You will see it first time in your paper only. Your seniors have not seen that question. So you will see that question first time in your exam only. So you should be prepared for the new MCQs also. For preparing new MCQs, you should read the textbooks, standard textbooks thoroughly. I advise you to read the standard textbook from the beginning. Read Robbins from day one. From day one, I suggest every student to read Robbins. Since any examiner who will frame new question, he will frame it from where? You should know the source now. Source is already known to you. He will frame from pathology, he will frame from Robbins. If it is pharmacology, he will frame from Katzam. If it is microbiology, he will frame from Anand Narayan, or some better books are also there. So you should read the standard textbook, not the small textbooks. So you should read that standard textbook for preparing MCQs. You should read small textbook for preparing your university exams. So in the last 2 months of your university exams, you should read smaller books. You should read Hirschman or some other books. KDT is there. So you should read that for preparing university exams. But for preparing your MCQs, for your next preparation, NEET preparation, you should read standard textbook. So always read standard and mark it wisely. Don't mark. I have seen many students marking every line of the book. So if you are marking every line, why you are marking now? Why you are marking? We mark a book so that in the second or third revision, we will mark, we will read only the mark thing. We won't read the complete paragraph. We will read that line only which we have marked. If you are marking it completely, why to mark? If you have to read it completely in the second revision, at least you should do 3 or 4 revisions before your competitive exams. So first time Robbins, you have to study in second prof only. You have to read it completely. Mark it with a color. Just suppose yellow color you are marking. In the second revision, mark it more wisely so that in the third revision you have exclusive things to read out. So you can revise complete Robbins say in 2 days or 3 days in the last month of your exam. So you have to do that at that level, not only with Robbins, with all the standard textbook. With Harrison also, I will say the same thing. So start reading Harrison now only. Mark it wisely. Mark it not as a, read it not as a student, read it as an examiner. If you are an examiner, I ask you to frame MCQ from this page. This is a page from Harrison, this is a page from Robbins. Just read this page and make a new MCQ out of it. How you will make a MCQ? So you just read by the examiner की नजर से देखो, ऐसा बोलना चाहती हूँ मैं. So I want to say like this. So just from what points you can make a MCQ, just mark those points only. Don't mark every line. Don't read it like a student. Read it like an examiner. If you are an examiner, you have to frame an MCQ from this page, from where you will make an MCQ. If you are able to make the MCQ, examiner will also able to make a new MCQ out of it. Yes or no? So you have to do like that. You have to do like that. Correct or not? So if you are prepared for your new MCQs, your selection is guaranteed. If you are prepared only for repeat ones, now your selection is doubtful. Now it depends on luck. If you are prepared for new also along with repeat, then your selection is guaranteed with a good rank. With a good rank. So that was all about the motivation speak till now. Okay. So we will come on the clinical features of the rheumatic fever. We are done with the 5 major Jones criteria. We are done with all of them. Now I am coming on clinical features of rheumatic fever. So mother is carrying child to you. You are a doctor to your clinic. Parents are carrying their child. What symptoms they will tell you. So you will have a suspicion that child is having rheumatic fever. Out of the 5 Jones criteria, anyone can be present in the child. So if the child is having carditis, child will have heart failure. And because of heart failure, if left heart failure is there, child will have dyspnea. So parents will say, my child is breathless. My child is having breathlessness or dyspnea during a small activity or even at rest. So that will be the symptom. Patients always give symptoms. To make diagnosis is your job now. So looking at the symptom, by compiling on all symptoms, you should have a suspicion that this can be the diagnosis or differential diagnosis, and you will do judiciously your investigations and come on a conclusion that this is the ultimate diagnosis, and you will give the treatment for that. So if the child is having carditis, they will not say you that my child is having carditis. They will say my child is having dyspnea, or my child is having syncope, my child is having pain in the chest. That is due to pericarditis. Fibrinous pericarditis causes pain. Chest pain is there in the child. So these can be the symptoms. Or subcutaneous nodules can be there. If the child is having syndrome scoria, that is very typical. Parents will say my child is doing purposeless movements in the air. My child is dancing like anything. So that will be the symptom given by the parents to you. And previous sore throat is there. That is the history you have to take. सामने से पेरेंट्स नहीं बोलेंगे. You have to ask the parents that whether your child 2 to 3 weeks before, whether the child is having sore throat or not. They will say yes, he was having sore throat also. There can be joint pain also, polyarthritis also. There can be edema due to heart failure. If right heart failure is there, edema is there. If left heart failure, dyspnea is there. I have told you yesterday only. So these are the symptoms given by the parents to you. What investigation you will order? You will write some investigation. No, you will say parents that I am thinking your child is having rheumatic fever, but I am having suspicion. For that, you have to confirm it. You will do some investigation. What investigation you will write on the prescription? Just do these investigation. So yes, you will do some blood investigation. That is ESR, CRP, C-reactive protein, and WBC count. That is CBC. So these 3 blood investigation you have to do. You have to do a throat swab and antibody, ASLO and DNA antibody, ASO and DNA antibody for supportive gas diagnosis, group A beta streptococcal diagnosis. You will order that, and you will order a chest X-ray also to see cardiomegaly is not there. If there is a heart failure, there can be cardiomegaly, na, or pulmonary congestion, pulmonary edema. So you will order a chest X-ray also. You will order a ECG also to see increased PR interval. Yes or no? And you will order echo also to see if valvular involvement is there or not. If valvular involvement is there or not. So these are the list of investigation you will order to the parents and ask them to come with the reports. And based on that, you will and clinical features also. You will make your diagnosis. What is the treatment you will write? What is the treatment you will write? So treatment is supportive treatment. You will ask the parents to give bed rest to the child. How bed rest will help to the child? How it will help to the child? Because child is having joint pain, so bed rest will help the child, and also it will reduce the cardiac workload. Say yes or no. If the child is having heart failure, right heart failure or left heart failure, you will give LMNOP treatment. LMNOP, that is a mnemonic. So L means Lasix. You will give diuretics, high ceiling diuretics, furosemide, torsemide, that is Lasix. Number two, you will give morphine. You will give nitrogen and oxygen, nitroglycerin and oxygen, and you will give high head position. LMNOP, that is the treatment. And rarely pacemaker is also required. If SA node that is not working, pace is not, pacemaker can be required. You will give aspirin for arthritis. I have told you dramatic response by single dose of Disprin or aspirin. So in arthritis, you will give aspirin, learn the dose by yourself. If it is a child, you have to give 60 milligram per kg. If it is an adult, you have to give 100 milligram per kg. And till ESR is normal, you have to give aspirin. That is the treatment. You can give steroids. In case of severe arthritis or severe carditis, you can give steroids. Steroid mein kaun sa steroid? It is prednisolone. It is prednisolone. That is the dose, 1 to 2 milligram per kg. So that is the treatment. And main treatment is antibiotic. You have to give antibiotic. Which antibiotic? Very, very important MCQ. You have to, there are two options. You will ask parents whether I should give injection or I should give tablets to the child. So if injection is okay, only single injection is required of benzyl penicillin. What is the dose? 1.2 million units. Single dose, 1.2 million units, benzyl penicillin is required. Single injection. If injection is not tolerable to the parents, no, don't give injection to my child, give some tablets. You have to give tablets for 10 days. Which tablet? Phenoxymethyl penicillin. Both are penicillin, but different. This is benzyl penicillin. That is phenoxymethyl penicillin, PMP, phenoxymethyl penicillin. What is the dose? 250 milligram 4 times a day for 10 days. So that is the treatment. If the child is having allergy to the penicillin, many childs have penicillin allergy, then you have to give erythromycin or cephalosporin. That is the second line treatment. So you have to give second line treatment. So what is the treatment? Tell me. It is benzyl penicillin or phenoxymethyl penicillin. Benzyl penicillin 1.2 million unit, a single injection, and phenoxymethyl penicillin 250 milligram 4 times a day for 10 days. That is the dose. And if there is allergy, then erythromycin or cephalosporin is the second line treatment. That is the summary till now. Have you got it? That is the main treatment with doses. Now this part is not from pathology. This part is from medicine. So I have covered medicine also here. So you have to understand the treatment also. So being a doctor, making diagnosis is your job, but giving treatment is also your job. So you have to give proper treatment to the patient also. Correct or not? And what is the prophylaxis? Parents will ask, okay, is bar to ho gaya. What we can do that again it won't happen. So what is the prophylaxis we can give? Is there is something we can give so that it doesn't happen again to my child? Because rheumatic fever occurs in recurrence. It is very recurrent disease. If it occurs once, it can occur in multiple times, multiple episodes. So it is a recurrent disease. So for prophylaxis, you have to give same antibiotic. Same. That is that is benzyl penicillin injection or phenoxymethyl penicillin oral. Same doses, 250 milligram and 1.2 million. Same doses. Till what? यहाँ पे तो इंजेक्शन एक ही दिन देना था, ट्रीटमेंट था तो बेंजाइल पेनिसिलिन सिंगल डोज था, और फिनॉक्सीमिथाइल पेनिसिलिन 10 दिन था, 10 days. For treatment it is either single or 10 days, either single dose or 10 days treatment. But for prophylaxis, since how? Some days, some months, some years, till what age you will give to the child? Child hai na? Till what age you will do? Still the child is 40 years or 21 years. Child will become 40 years of age or 21 years of age, depending valvular involvement hai ki nahi hai. If valvular involvement hai, to you will give till 40 years. And if valvular involvement is not there, you will give till 21 years. What you will give? Benzyl penicillin injection every month, once every month. हर महीने एक इंजेक्शन लगेगा. कब तक लगेगा? जब तक बच्चा 40 साल का नहीं हो जाता. Have you understood? Do you understand Hindi? So you will give benzyl penicillin 1.2 million injection every month, once a month, till the child become 40 years of age. If valvular involvement is there, and if valvular involvement is not there, till the child become 21 years of age. Till the child become 21 years of age. Yes or no? That is the profile axis. That is the profile axis. So we are done. We are done with the first endocarditis. I have to teach you 4 endocarditis now. So that was the first endocarditis, that is rheumatic heart disease. 3 endocarditis are still remaining. That is Libman-Sack endocarditis, non-bacterial thrombotic endocarditis, and bacterial or infective endocarditis. So these three, the remaining 3 endocarditis, I will cover in the next lecture. Now there is no class tomorrow on Wednesday. There is no class. Next class is on Thursday. Next class a day after tomorrow on Thursday on 6th of May. So next class on 6th May, Thursday, same time in the morning, Thursday at 11 a.m. At 11 a.m. I will continue with CVS only. So CVS episode 3 will be there. I will continue with endocarditis only. After covering endocarditis, I will teach you hypertension. I will teach you atherosclerosis. I will teach you aneurysm, all the important MCQs based on it. And if time allows, we will do vasculitis also. It is very important. Many types of vasculitis, many MCQs come on it. So class is not there tomorrow, a day after tomorrow on Thursday. I just give me a second. I request you all to join my Telegram channel for getting the links of these free classes. Just a second. Yeah. So thanks for being awake and be with me. I will appreciate your feedback. Just write your feedback, whether it is positive, negative, whatever your suggestion, just write in the chat box. I will appreciate if you give the feedback to me. And next class is a day after tomorrow. Please follow my profile link on Unacademy for getting notifications 15 minutes before the class. My name is Dr. Priyanka Sachdev. Search on the Unacademy app in free classes. You will get my name, you will get my profile link, and just follow it. You can use the code Sachdev10 for getting 10% off on plus subscription if you are thinking of taking the plus subscription, and if you want to unlock the free classes. So my classes are free. Just share this code with all your batchmates on your batch groups. So just share the code. Sachdev10 is the code. I don't mind. Just share the code with every medico you know, and you can unlock my free classes using this code. The code is Sachdev10. Sachdev, that is Priyanka Sachdev, my name. So just use this. See you in the next class. And yeah, my Telegram channel is MedLife by Dr. Priyanka.